renal pathology, hydronephrosis, as well as urinary incontinence. Hydronephrosis, I'm just going to be quickly covering it. All it is just distension and dilation of the renal pelvises and calyces, and it's usually secondary to the fact that patients have essentially regurgitation of urine back up through the ureters and affecting the kidneys, and it's going to go into the renal pelvis and calyces to cause that dilation and distension. That's all that hydronephrosis is. Don't get too lost in the weeds with that. Now for urinary incontinence. So urinary incontinence is one of those things that I struggled with so much. And honestly, when I first saw it, I was like, oh, this is just like definitely so low yield. But in reality, they ask so many questions about it. It's actually somewhat in yield. So you have to know each of the incontinences, and they're not too bad once you actually learn them. If someone teaches you it, it's relatively straightforward. So just follow along with me real quick. If you have any questions on this, please reach out to me, because this was one thing that I struggled with, but then I realized it really isn't too bad. Okay, first thing, stress incontinence. Okay, stress incontinence, it's in the name. If you have any stressful force being pushed down on the bladder, it leads to the leakage of urine. Okay, so what does that mean? That means that I usually have a urethral hypermobility, or I have an intrinsic sphincter defect or deficiency. Okay, so why does that make sense? It makes sense because if I have urethral hypermobility, that is what's going to lead to the urine leaking out if I add any stress on top of the bladder, right? Any pressure on top of the bladder. Also, if I have intrinsic sphincter deficiency, any bladder that's being pushed down, it's going to leak out fluid or urine because that intrinsic sphincter isn't tightly closed, not allowing for any urine to flow out, okay? So this leaks with any increase in intra-abdominal pressure. Patients are going to have like sneezing, coughing, laughing, lifting, anything like that can lead to our urinary incontinence. Now, the association is obesity and pregnancy, okay? So patients that are obese or patients that are pregnant have an increased risk for having their urethral hypermobility or intrinsic sphincter deficiency causing stress incontinence, okay? The treatment for this is pelvic floor muscle strengthening exercises, okay? It strengthens the levator ani muscle complex in order to stop the stress incontinence from occurring, okay? Now, up next is going to be urgency incontinence. So for urgency incontinence, it means that essentially you have to pee, and then right when you feel like you have to pee, you immediately start to urinate. Okay, that's all it is. So like urgency incontinence is like you have no time to go to the bathroom. You feel like you have to pee, and then right then and there you pee. Okay, and this is due to detrusor overactivity. Now the question is, what is the detrusor? The detrusor muscle is just the muscle that is within the bladder and helps us, right, urinate. So if we constrict the detrusor muscle, we urinate. When we relax it, we stop urinating, okay? So when we have detrusor overactivity, it's constantly kind of spasming and contracting randomly, and it causes the leakage, okay, when you have the urge to void immediately. Okay, so the patient will present, hey doc, I needed to go urinate the other day, and right when I was about to urinate, every single time I just feel like I have to urinate, and then boom, I urinate automatically. Okay, and that's due to detrusor overactivity. They will ask that question, okay? Important associations with urgency incontinence specifically is going to be MS, okay, multiple sclerosis. For MS, the patients will develop urgency incontinence, due to the fact that they lose the CNS inhibitory neurons that normally inhibit the detrusor muscle. Okay, does that make sense? That's very, very important to understand because they like to ask about MS's association with urgency incontinence. And it's due to the fact they lose those CNS inhibitory neurons of the detrusor muscle, leading to detrusor overactivity and then leaking with urge to void immediately. So a lot of the time you're going to see within the vignette a patient that might have MS or neurological deficits. So keep that in mind. Last but not least, we have overflow incontinence. Overflow incontinence is just the incomplete emptying, okay, of our bladder, and it's usually due to detrusor underactivity. So opposite of urgency incontinence, we have detrusor underactivity. And so since we have detrusor underactivity, the bladder is just going to fill and fill and fill and fill and fill. And once it's fully just to capacity, the urine has nowhere to go except for out. So you just start to dribble, you start to leak because it's overfilling, it's overflowing. All right. And the number one cause of this is usually diabetics. Okay. Because diabetic patients, they have the loss of the feeling of the bathroom. So, you and I, we have to go to the bathroom. We feel that. However, with patients that have diabetes, they have neuropathy. And with that diabetic neuropathy comes the inability to feel if you have finished peeing out your full bladder. Okay. So they usually have incomplete emptying of their bladder when they go to urinate. And then that bladder over time starts to fill up. And then that's when we get overflow incontinence when it's fully full. Okay, that's pretty much all you have to know about these urgency incontinences. Once again, very, very hard for me to begin with, but when you talk them through and understand what's going on, you should be fine. I think the key aspect to all of these is the mechanism in which it occurs, right? So stress incontinence is going to be increased intra-abdominal pressure, and it's due to urethral hypermobility or intrinsic sphincter deficiency. Urgency incontinence is due to detrusor overactivity, seen in MS patients mainly. And then overflow incontinence is due to detrusor underactivity and usually seen in diabetics, okay? Lastly, just for the anatomy of the bladder, the dome of the bladder rises into the peritoneal cavity. So if anything were to happen to the dome of the bladder, like let's say it ruptures, you're going to have urine and fluid within the peritoneal cavity. So keep that in the back of your mind. I know it's random, but it was something that I wrote specifically in my book, and I needed to know it for that specific section, okay? That's all.